Hello, everyone. My name is Brian Shah. I want to thank Dr. Yanios for giving me this opportunity to present in front of such a great group of people. I know we're doing this virtually, but I still am quite honored and am very, very proud of the work that Dr. Yanios is doing and happy to be here. So when Nick originally talked to me about doing a presentation, we had decided upon outlining the protocol that Dr. Piper and I use here in the clinic when we evaluate a patient. Given this new setting, being able to do this virtually, I thought it would be a good idea to give folks even more of a background as to why we do some of this stuff and why our evaluations are so comprehensive. So I've put together a presentation that has a little bit of a broader background. It's an introduction to TMJ surgery, which of course is largely what Dr. Piper and I do here in St. Petersburg. So we will run through that presentation, and I think in this setting I'll be able to delve in a bit more into each of these different perspectives regarding TMJ surgery and the TMJ patient. So I'll go ahead and get started. And again, thank you, Nick, for letting me do this. So to organize what we're going to go through today, I put together a roadmap, and we're going to try to hit these bullet points to get the point across. Number one, we want to look at the history of TMJ surgery. I always try to do a little bit of history with presentations, and again, it's not going to be anything more than just a little bit of history. And the reason why I do it is twofold. Number one, it gives us a better understanding of why we're doing things the way we do presently. And number two, it's really to pay homage to the brave doctors that came before us, who were willing to take chances on things and to help patients in ways that haven't been done before. All of that activity benefits us and our patients in the present day, which will move us to point number two, which is present day TMJ surgery. I'm going to quickly go through the gamut of what most people are offering out there without doing too much of an editorial. So I'll try to be fairly objective and just report the facts on that. We will then do a quick MRI primer where I will quickly go through the salient points of a T1 and T2 MRI scan, as we use these frequently. Next, we'll look at who needs the operation, and this is the bulk of our workup. What we're doing when the patient comes to the Piper Clinic and why we're doing it. And then we'll finish with a case study at the end. I have a little bit of surgical video also embedded at the end of this presentation, which I think could be interesting to some folks for sure. So when talking about the history of any sort of medical or dental procedure, like I said, we really have to respect those that come before us. This is the Ether Dome at Massachusetts General Hospital where I trained. This is where I would do grand rounds every week and get beaten up by my professors. But this painting depicts a surgeon removing a jaw tumor using ether for the first time. And if you can imagine the courage and will of these doctors when doing something like this for the first time, who knows what sort of potential side effects could have occurred, and how brave they must have been to go forward with this. So I think we should respect that as we think about the work that Nick has done with his group, kind of being trailblazers. The history of TMJ surgery can be summarized on this slide, and I know there's a lot of verbiage, but it really kind of takes us from the beginning to where we are now in a timeline sort of fashion. So in 1887, Annandale reported for the first time on intrajoint surgery in the British Lancet, and it was called the displacement of the interarticular cartilage of the lower jaw and its treatment by operation. So essentially, this was a operation where they were entering the joint to fix pathology that they noticed via physical examination that resulted in a displacement of the articular disc, and that was back in 1887. In 1909, Lanz introduced the discectomy for treating painful internal derangement. So all the way back in 1909, Lanz was removing the disc to get people feeling better from articular cartilage displacement. In 1914, Murphy published on fat grafting and gap arthroplasties. So gap arthroplasties are bony defects that are created by the surgeon, typically in cases of ankylosis, where the bones grow together at the level of the joint. You have to remove a certain amount of bone, and it creates a gap. So what Murphy did is he placed a fat graft in this gap to allow the patient to function. In 1934, Risdon came along and used muscle. Typically, this is going to be the temporalis flap that we all hear about, where the temporalis muscle is folded into the joint space to create some sort of cushioning. In the 1950s, the standard of care was discectomy in Europe, and that was done by Bowman and Erickson. So again, all the way back in 1950, this discectomy was being done and being done successfully. In the 70s, Wilkes, Farrar, and McCarty popularized disc repair and repositioning. So they realized that if this cartilage was not beyond repair, meaning abnormal in size, shape, or perforated, they could try to repair this or reposition it for the patient. In 71, Christensen described the total joint prosthesis, which has gone through an evolution, and there are many other iterations of that are being used presently. Now, in the 1980s, the reason why I put this in red is because this was a bad time in TMJ surgery. This was the time of the alloplastic disc replacement. So as you can see, many years prior to the 80s, people were taking out the disc and putting either nothing in the joint, and patients were functioning successfully, or using autologous tissues such as fat or muscle. In the 80s, however, the thought was we can do this better, man-made materials can work better, and the Teflon Proplast implant was introduced and used. And as you'll see in my next slide, that complications arose, and that then helped the birth of arthroscopic surgery and arthrocentesis, largely popularized by Onishi in Japan in 1975 because it was minimally invasive. And people had such a bad taste in their mouth from open procedures because of the Teflon Proplast implant. So here's a case report that really gets to the heart of what was going on with these patients treated with the Teflon Proplast implant. So essentially the disc is taken out, the bones are either plastied or not, and a cushion made of Teflon Proplast was inserted between the skull base and the condyle. This woman had her procedure done many years earlier and developed this left-sided facial swelling. You can see it's getting so large that it's visible from a distance. She also has ptosis of the left eyelid on that side because of nerve compression. When you look at the axial image of the CT scan, if you come to the left side of your screen, which is going to be over here where my arrow is, you can see this border enhancing lesion in the area of the preauricular tissue. Now, once this is entered and examined, you can see that there is an incredibly large lesion, and in this screen, the pathologic screen, you can see that it's attached to the implant itself. So this was an untoward reaction to this man-made material that we started to see in many patients. Now, a lot of this was happening just as I was beginning training. So I was seeing the tail end of this in my residency program where patients were coming in to have these things removed, and the referrals, as well as the patient, and also in many cases the surgeons, were incredibly gun-shy. They didn't want to go back in and operate on these people. This is the histology. The white segments here are actually the morselized Teflon proplast that broke down through use, and the body created a giant cell reaction that went unchecked and caused these giant cell lesions. So that moves us into what we're doing now. And again, this is because we are gun shy. It's conservative first, and it's insurance driven. There was so much money spent on those procedures, not only the first time they were done, but to remove the lesions as well as the implants, then reconstruct the patient, that insurance companies caught onto this and said, hey, we're not paying for TMJ surgery unless it's something like an arthrocentesis or arthroscopy. So those gained popularity in the present time. I have in light blue open procedures such as disc repair and repositioning, discectomy with and without grafts, autologous construction and reconstruction, and alloplastic total joints. The light blue is really where Dr. Piper and I live. This is what we're doing most of the time. If we were to see an indication and a reason to do arthroscopy or arthrocentesis with our patient base, we would do it. However, that's typically not the way they present. So I will start with kind of defining all of these things. Like I said, I'm going to try not to editorialize too much and just give the facts and the reason for these things. So the arthrocentesis can be done with or without medication, and this is typically what your local oral surgeons are doing. They're washing out the joint, and the concept is less about dislocation and more about synovial joint function and inflammation. Hills and their group described a boundary of phospholipids that are important in joint function. So the inside of the joint is lined with this phospholipid layer. Rahamim showed that hyaluronic acid binds and protects this phospholipid layer from phospholipase A2, which is an enzyme that would break that down. Then Nitzen came and brought some very interesting research that showed that parafunctional jaw activity can cause excessive compressive stresses within the joint, and it causes a hypoxia reperfusion cycle. So in other words, things get squeezed, blood gets squeezed out. With the blood getting squeezed out, the oxygen gets squeezed out in an abnormal way. Then as it reperfuses, it brings oxygen-free radicals, and that was shown by Moe. And those free radicals degrade the hyaluronic acid, shown by Grootveld. Now again, the concept is that the hyaluronic acid gets degraded, the phospholipids are not protected, and we have a poorly lubricated joint, and this then leads to intra-articular damage and inflammatory mediators that cause pain. So the whole concept with the arthrocentesis is to wash out those inflammatory mediators and allow the process to start over again. Now, unfortunately, as you can see, you're not treating the pathology. You're treating the secondary effects of the pathology, which is parafunctional jaw activity and the mechanics of the joint. This is what it looks like. It's very straightforward to do in the office. People either use sedation or local anesthesia, depending on the patient profile. And you're blindly placing two 18-gauge needles, or whatever size the surgeon prefers, into the superior joint space. And what you have is an entry point, which is the one with the syringe attached to it, and an exit point. If you're in the correct position, you're now able to introduce saline, lactated ringers, anything you want into the superior joint space and wash it out in theory. Again, you have to be exactly where you think you are. And this is not done with imaging, so it's done by feel. And you can take from that what you'd like. Arthroscopy, or taking a scope or camera and using it to perform surgical procedures, was really popularized in the temporomandibular joint by Dr. Joe McCain in 1988 with this seminal article. And what Dr. McCain did is, with patients he knew he was doing an arthrotomy on, meaning opening the joint to treat pathology, he used these new techniques at the beginning of the procedure to visualize the joint and record data, and was quite successful in doing that. The concept is to use this very small scope and working instruments through multiple ports in the superior joint space. So the same thing as arthroscopic procedures in the abdomen. Here we're doing it in the joint space. The downside is in the abdomen, you can insufflate the tissue and have a lot of room to work. Here you can't really do that. You can use fluid to keep things tented, but you're not able to push bone and cartilage and everything out of the way to a great extent. Now, it's really been popularized, and Coslin has listed many things that it can be used for. Closed lock with anterior disc displacement, painful popping, joint adhesions, perforated discs, inflammatory synovitis. Now, the reason why I have joint adhesions in black is because I believe, you can break up adhesions with a working end of these instruments. I don't know exactly how you're going to treat painful popping, which, as you know, is dislocation and relocation of the articular disc. A closed lock, if it's secondary to pain and inflammation, maybe, but how are you going to put that disc back in place? Perforated discs, you're really not going to be able to repair that tissue in any meaningful fashion. And synovitis, there has been work with lasers through the ports to decrease that inflammation, though again, I'm a little skeptical on that. This is a representation from Dr. Yang, who is doing a lot of work and research with these scopes. And what you see are and he uses multiple ports, by the way. But in this photograph or diagram, we can see that 2 entry points have been made into the superior joint space. And the corresponding photographs through the scope show visualization of the disc, the eminence, and you can see different changes that have occurred within this joint in the way of vascular injection and erythema. This is also where you would see adhesions and so on and so forth. Now, disc repair and repositioning. The concept is to position the disc back to where it would be in an uninjured person. So according to Dr. Piper and I, this would be the 1 o'clock position when viewed from the sagittal and centered over the condyle when viewed from the coronal. You can't ignore the different portions of the disc just because you can't see them easily. So this is data that's been gained from MRIs and from opening the joints, but you have to get the disc on top of the entire condyle. If the disc is overly deformed, it's not going to work because it won't sit passively in the position where you placed it. And most importantly with this entire concept, and I'll show you this later in the talk, the occlusion has to be controlled. If the occlusion does not match what's going on within the joint, as soon as the patient is allowed to function, the disc will be displaced again. The herniation pattern must be amenable. So an anterior medial displacement is easier than an anterior lateral displacement, because if you can imagine, you're reestablishing what has failed. And if it's anterior and medial, you're reestablishing the posterior attachment as well as the lateral attachment. Reestablishing the medial attachment is very difficult because you simply can't get there. And we do this on children and growing children to reestablish the growth of the condyle. Dr. Piper wrote this in the Oral and Maxillofacial Surgery Clinics of North America in 1989 to really detail both the anatomy of the temporomandibular joint and his technique on doing this through the microscope and repositioning and preserving the disc. This is largely exactly the way that we do the cases still now to this day. And the real advantage, in my opinion, is that you can see what you're doing. You're looking at things three-dimensionally, again, through the scope. I'm sure that there are people that can make it happen, but it's very, very, very technique sensitive. So these are diagrams from Dr. Piper's paper. And what I'm going to do is quickly run through these from left to right, left of the screen to right, to go through the steps of what we're doing when we do these types of procedures. So first, starting on your top left, and my arrow is hovering in that area, we're dissecting down to the capsule of the joint and doing the arthrotomy. So entering the superior joint space by creating an incision through the tough fibrous capsule of the temporomandibular joint. This is the bone, here the zygoma, and here's the condyle, and we've entered that space. Next, we'll likely encounter adhesions. So these are scar bands between the moving components of the temporomandibular joint. These have to be taken down. If the adhesions are not taken down, the disc cannot fit passively on top of the condyle and adherent to where it needs to be. So that's done. Here in the next photo, or diagram, I should say, you can see that we're using a blunt nerve hook in the inferior joint space to mobilize the disc in the tissue. And this is sort of a little bit of a test. We're checking to see if this disc is going to passively sit back on top of the condyle and what potential work we're going to have to do to get it to do that. And that's going to be a tactile thing. We're visualizing, but a lot of it is, where is this disc hung up? Typically, you're going to get fibrosis and scarring of the superior belly of the lateral pterygoid. And in this portion of the diagram, you can see where the knife blade is doing a gentle myotomy. In other words, cutting through a superficial portion of this superior belly of the lateral pterygoid to allow this disc, here in white, to fall back posteriorly because it's been scarred forward in that position over time. So again, this is a little bit of a back and forth. You don't want to cut too much, but you can't cut too little. If at this stage we find that the disc is not going to passively position itself, it may be time to abort the procedure and do a discectomy instead. Now, if we get the disc to move from anterior to posterior, but there is hypertrophied tissue at the back end of the disc, or the retrodiscal tissue, this is going to have to be removed in a wedge fashion. So in this technique, hemostats are used as a pie, almost, with an apex and a base. And this is the medial portion where the apex is, and the base is at the lateral. And those are clamped, and then the tissue is excised. And that creates a gap or a wedge where now this disc can fit posteriorly and passively. In the next diagram, we have a sharp towel clamp that's been placed through the tissues down onto the inferior border and angle of the mandible to manipulate the jaw in multiple positions without having to put our hands in the mouth. Because remember, this is a sterile procedure. The mouth has been prepped out of the field. So we're manipulating the mandible superiorly and wanting the disc to sit passively on top of the condyle in the correct position. So again, it's a back and forth stepwise process. In this diagram, what often occurs is the disc deforms. Okay, so it's been in the wrong position, it scars a little bit, and it needs to be plastied. So this is a representation of plastying the superior portion of the disc, which is typically the area that deforms, luckily, because it would be harder to get to the inferior portion. Once that's done, we recheck, go back to this area here, make sure everything is passive, and then the disc can be sutured in place using a 4-0 PDS suture in a buried figure of 8 fashion. Okay, so the knots are going to be deep to this tissue and less likely to irritate the patient. So that is a disc repair, disc repositioning using the Piper technique. The MRI from the sagittal shows here a displaced disc. Here's our condyle. This is anterior. The disc is anterior to the condylar head. This is after repair. The disc is back in the 1 o'clock position and protecting the condyle. So discectomy is the next procedure. This is sort of the workhorse of what we do in the practice. The concept is that we remove a displaced, non-salvageable disc to improve function, decrease pain, and prevent further bone degeneration. Again, it was successful since 1909. there is some controversy regarding how to replace this disc once it's been removed. In 1909, they weren't replacing it with anything. We use autologous fat, and we have a 23-year follow-up with MRI-verified viable fat grafts. So in other words, these are going to glow on T1 MRI images, and we have those reported in our practice. Demetrulis and others have shown histologic and imaging viability of the fat graft in the TM joints. Wolford has also shown this, and he's shown that there is decreased ectopic bone formation when you place fat around total joint replacements. We use this fat because it does not need to be tacked down. That can always slip or fail. It lasts, it cushions, and it's autologous, so we don't get a foreign body reaction. This is histology from Dr. Wolford of a fat graft biopsy taken 4 years after implantation around a TMJ Concepts total joint prosthesis, showing that the fat is viable without evidence of inflammation, heterotopic bone, or significant fibrosis. So when you don't have enough autologous structure left, meaning your condyle is resorbed away, or there has been ankylosis, trauma, significant arthritic disease, malignancies, or large neoplasias, you can't do the discectomy with fat grafts, obviously. You have to rebuild, you have to rebuild what was lost. And this can be done with bone grafting. People have used the calvarium, the sternoclavicular joint, the iliac crest, and we found that the costochondral rib graft is the best tissue to use. The disadvantages of doing this is that you do have a donor site. There's an incision in the chest, which in theory could cause a pneumothorax. We're always checking for that pre, intra, and postoperatively. There have been many reports that these can be unpredictable, that they grow asymmetrically or cause skull base perforations. I had a lot of experience with these when I trained with Dr. Cabin at Mass General, and we use these every time when we were constructing a hemifacial microsomia patient. And Dr. Cabin's papers talk about controlling the cartilaginous cap, making sure that there is not excess cartilage, and therefore you can control the growth. This is very technique sensitive, but can be done. Here's a couple images showing the rib graft. Here's the incision. The nipple is here. This is the bone with the cartilaginous cap. Here we are in the face, screwing the rib to the ramus, and also checking to see where it articulates in the joint. This, again, is very technique sensitive, but can be done. Alloplastic joints have become more popular amongst most surgeons. Dr. Piper and I still like to use the ribs if need be. We have our reasons for that can be discussed at another time, but the alloplastic joint is being used quite frequently by most surgeons at this point. The concept is to reconstruct the end-stage pathology just as you do with a bone graft. And the advantage would be that these things can be developed on the computer and made to fit the patient specifically. The disadvantages is they can be unpredictable with regards to component wear. There can be hypersensitivity to the materials. There can be mechanical failure. Heterotopic calcification is also seen in the joint space. Cost, and how long will they last? These are all things that are being researched intensively right now, not only in this country, but overseas as well. This is a photograph from Dr. Wolford's website showing conceptually what these look like. You have a fossa component, which is screwed into the zygomatic arch. So here you can see there's 4 screw holes. There is an articulating surface, which is in a high-density plastic, basically. Then you have a condylar ramus component, which is screwed into the remaining ramus of the mandible. Now, the condyle does need to be amputated for this sort of prosthetic to work, and therefore you are removing the attachments of the lateral pterygoid muscle. So that completes the section on modern procedures for the temporomandibular joint. This is going to be the 2-second MRI primer. So the T1 scan is up here I just put fat, because that's all you really need to remember on this one for what we're doing. The T1 is going to illuminate fat and not water. So as we look at these two images, a sagittal view and a coronal view, both in T1, to orient ourselves a little bit, we have the earwax, so this is the ear canal here. The anterior is on the left side of the screen for the sagittal. For the coronal, this is the skin and the subcutaneous fat. So this is the lateral, this is the deep, and here's the brain in both of these issues. Now, the reason why we use these is, number one, to look at the disc, which is typically going to have a bow tie, dark gray appearance. We also use this to look at the bone marrow. Marrow is largely made of fat cells, so we want to see a homogeneous white glow in a healthy joint. We can also see joint space, so we can see if there's a likely perforation, and we can see the anatomy of the surrounding tissue, the muscle, as well as the vascularity. Okay. In the coronal view, we do the same thing, but we're looking at the disc slightly different. So here you can see that the disc is displaced medially. And I think this is one of the things that Dr. Piper was really a pioneer on, is we can't just look at the disc from the sagittal. That doesn't make any sense. The disc is a three-dimensional structure. It may look reasonable from the sagittal, but if you look at it on the coronal, it can be displaced medially or laterally, and all of those things can cause symptoms and secondary problems. Compare the T1 to the T2. So T2, like H2O, is water. Okay, that's a basic way of looking at it. So these signals are going to be a little bit different. The way you can tell it's a T2 image right away from a distance is to see if the CSF lights up in the brain. So if we go back to the last one, the brain is fairly homogeneous. We're looking at myelin in the nerve tissue in the brain, but we can't see the CSF. So here we see the CSF. Okay, so you know this is a T2. In this image, we're looking for edema, both within the surrounding tissues, that's going to glow white, and we're looking at it within the marrow itself. So if there's active edema within the condyle, we're going to see that as bright white regions. And again, we look at it from both the sagittal as well as the coronal. Herniation patterns are fairly straightforward, and we don't have to spend a ton of time on this. The disc, the posterior band, should be in the 1 o'clock position. As it herniates forward, it can slip to the 12 o'clock, the 11 o'clock, or the 10 o'clock. In all of these images, you can see the disc moving forward and forward. Now, the only thing I'll bring up here is there is some controversy amongst radiologists and practitioners saying that the normal position should be 12 o'clock, not 1 o'clock. To us, this doesn't make a lot of sense. The posterior band of the disc is the thickest portion of the disc, typically around 3 millimeters. As you get into the 12 o'clock position and 11 o'clock position, that's the concave region of the disc that should be approximately 1 millimeter in thickness. Now, that fits the condyle fossa. If you were to take the posterior band and put it right at the apex of the condyle, that would cause pressure inferiorly into the condylar head itself and superiorly into the fossa. And we actually do see that in 12 o'clock discs. We see morphologic changes in the anatomy on the CT scan. So now we're in the section where we really, the nuts and bolts of what we should be talking about. Who needs TMJ surgery? This is such a controversy in the dental world as well as the medical world. And I'll be honest, it was a controversy for me as well before I joined Dr. Piper and understood that these things are not magic. We're going to approach these patients just like we would approach any surgical patient. So the same patients who require any type of surgery are the patients that require TMJ surgery, meaning, is there identifiable pathology? Can we see the pathology? Does this pathology cause signs and or symptoms? Would surgical treatment of this pathology predictably decrease or remedy these signs and symptoms? Would the potential complications from surgical intervention be acceptable in this specific patient? We have to do a risk-benefit analysis. And lastly, would failing to operate on this patient lead to an unacceptable progression of signs and symptoms? Very easy to look at these things and apply it to any operation. Now, the gray zone always becomes the risk-benefit analysis, which of course we undertake with the patient. But as long as we have objective data, we can have that conversation with them. In other words, it's all about the diagnosis. And I have a quote from another TMJ doctor here, just so you know that we're not totally slanted towards what Dr. Piper and I think. But Nitzen states, TMD is a commitment-free term that clinicians and researchers frequently use that avoids well-defined differential diagnoses, thereby providing poorly defined diagnostic criteria for clinical research and, in many cases, indiscriminate treatment. So this goes to everything Nick is doing. Measures matters. You got to measure things, and it matters. And that's what we're trying to do. We're trying to get objective data to help our patients. So we spend all day trying to get this diagnosis. We have an entire list all day long. They come in at 7 a.m. and they often leave at 9 p.m. It's a long day, but we have to generate all this information, and we don't want to have to make them come back 30 times to review this stuff. A lot of our patients are coming from other locations, so we want to get it all done in one day. So of course we're going to get our imaging, CBCT, MRI. Those are done with specific wax bites. Now we do use Blue Moose for this, and we're going to take them in the fully seated position, incisal edge position, and they will scan them in an open mouth position and MIP. But we don't need to get a blue bite for either of those things. History and physical is going to be done. They're going to watch some videos, some educational videos. We're going to get photos of the face, their static dentition, as well as their dynamic dentition, and that's them going through multiple ranges of motion. Instead of alginate, we're going to do trio scans and mount those models. Nerve blocks may be employed. And then by the end of the day, a PowerPoint will be created so we can go over all of this information with the patient, and then we'll debrief them at the end of the day. So how do you do that in an organized fashion? This is what scares people regarding TMJ patients. They come in, they're in pain, you're looking at them from the outside, everything seems okay. Where do you make your incision? What do you cut out of this person to make them better? What medicine do you give them? Well, you can't even think about those things until you get a diagnosis. And the only way you can get a diagnosis that is accurate is by being organized. So we're going to use Dr. Piper's triad to do this. We're going to look at 3 areas: the structure of the temporomandibular joints, so that's bone and soft tissue, their pain patterning, and that's broken up into pain pies 1, 2, and 3, which I'll go through. And we're going to look at the secondary defects: occlusion, skeleton, airway. As you get good at this, and what Dr. Piper always says is, you know a TMJ patient at hello, because I'm seeing these as they walk in the room. The skeleton, the face, I can say, oh yeah, there's something going on at the foundational level. So number 1 in red, the joint. Okay, bone disorders first. So we're going to look at bone and soft tissue. Bone we evaluate with the CT scan. And osteochondral growth deficiencies are things that we see all the time. This is an underdevelopment of the condyle, typically secondary to disc displacement during growth. So the growth center does never reach its potential, typically a childhood injury. Micro and macro traumas can do it, so they don't need to be hit with a baseball bat. This can be a small fall, and a very young child can do lots of damage. We look at and compare normal to abnormal. So a normal condylar volume should be 120 to 140 square millimeters, and the condyle should fill up 60 to 66% of the fossa. So these are objective data points that we're using. Here's a patient. This is our typical 2-dimensional TMJ screen that we show the patient based on the CT scan. We have axial views, we have coronal views, and we have sagittal views. So are these joints 120 to 140? No way. They're very small. How about how much of the fossa do these joints take up? Well, they're not taking up 60% of the joint, so we know that they're small. We also see other things here. There's flattening of the condylar heads, there's an osteophyte, there's evidence of arthritic irregularities here. Also, the spacing at the anterior portion of the condyle is abnormal on the right side and abnormal on the left side here. But in other words, we're looking, okay? Osteochondritis dissecans. This is damage to the marrow immediately beneath the surface of the condyle from chronic overloading. You're going to see decreased signal on the T1 scan. So that's the fat scan. It's not going to glow as bright in the area where we have the overloading. And this is often functioning anteriorly on the eminence. We can see this with class 2 patients that posture forward all the time to incise food. We can also see it in patients that have a device made by their dentist to position the mandible forward for any number of reasons. This is the T1 scan showing the loss of heterogeneous bone marrow glow. So we see the dark area where the joint is being overloaded. Avascular necrosis. So this is death of bone marrow of the mandibular condyle secondary to anterior locking of the disc with arterial deformation or chronic contusion to the condylar surfaces. So at the anterior medial portion of the joint space, the arteries from the internal maxillary artery run through the different areas of the lateral pterygoid muscle. These then feed the condyle. These vessels are very small and can be blocked by the thick articular disc if it has herniated forward and medially. If that happens, you're not going to get adequate blood flow to the condylar head and you'll get necrosis of the tissue. The way that looks on these coronal scans, T1 images, is loss of a homogeneous marrow cavity. So again, the first cell line to die is going to be the lipid cells or the fat portion of the bone marrow. So it can look similar to the osteochondritis dissecans, but typically it's a larger area and it's more heterogeneous. Oftentimes there's a lot of bone changes that have already occurred in these condyles as well. Osteoarthrosis, irregularity of the condyle or skull base resulting from disc displacement with development of surface arthritis. And we're going to see subchondral cysts, which are little dark areas below the cortex of the condyle. That's synovial fluid that's being pushed through the soft cartilage or chondromalacia that occurs. There's going to be sclerosis, and you're going to see that as very white, dense areas of bone. There can be irregularities and erosions, so that's active bone loss. And osteophytes, that's the bird speaking that we often hear when viewing the condyle from the sagittal. So on this scan, we come over here, look at these sagittal views, tons of bird speaking, abnormal shape to the condyle itself, irregularity of the apex of the condylar heads, and also small size of these condyles. There's flattening of this condyle when viewed from the sagittal. On the next film, we look at it three-dimensionally, and we do this with all of our patients as well. You can see that the patient's left condyle has more resorption and irregularity and morphology when compared to the right condyle, though the right condyle also has irregularity. And when we go really close up, we can see these little cysts, subchondral cysts. So below the articular cartilage, synovium gets pushed through there because the cartilage is soft. It's chondromalacia. And here is a small osteophyte with some sclerosis and density as well. So the last section we just covered bone pathology, and I hope I've shown you that we are looking at this objectively. I can't guess as to what's really going on with the bone morphology. We can see skeletal asymmetries and so on and so forth, but I don't know exactly what the joint looks like unless I image it. So we've got to measure, and that matters. Okay, so we're going to use a CT scan to do that. Now, the other part of the joint that is important and can't be ignored is the soft tissue, and that's going to be the disc as well as effusion and edema. The Piper classification takes a very specific look at the articular disc, and what Dr. Piper did, again, that's different than other classification systems, is that we're looking at both the medial and lateral poles of the disc to make these classifications. So I'm going to quickly go through this, and if you group them, it's really quite easy. So 1 is going to be a normal disc, intact ligaments. 2 is going to be the patient where you get this laxity with an intermittent click. You may not even catch this on the MRI. This could be a completely asymptomatic patient. It may even be one of you listening to this, that you get the occasional click, but we wouldn't really see anything on an MRI. The 3s, Roman numeral 3, A and B, is when we have laxity and herniation at the lateral pole. So the medial pole is okay, but the lateral pole is slipping. A means it slips but pops back, so you get a click. B means it slips but does not pop back. It's locked out. The lateral is locked. You're not going to get sounds with these ones. So that's 3. 4, we're now going to include the medial. Okay, so 3 was just the lateral. 4, we're including medial. So medial and lateral for 4s. A is going to be similar as the 3. It pops out, pops back in. Okay, so you got a click. B pops out, does not pop back in, no noise. Okay, so now what's the distinction with the 5? 5 is that we are herniated. To be herniated, by definition, the disc has to be locked out of position. So if it's a 5, we know there's no reduction of this disc, and we know that it's perforated. The difference between A and B is A is an unstable condyle. The bone projects to be unstable. So that's avascular necrosis, it's edema, it's evidence on the MRI scan that this bone is going to break down and cause occlusal changes and loss of more bone volume. B's are stable. So these can often be older patients that have condylar sclerosis, and the condyle is very dense. It's abnormal bone, but it's maintaining its height and volume. Excuse me. Typically, these patients do not lose volume and don't have occlusal changes. So even though this is at the bottom of the list because it's bad, these patients may not need surgery. You can watch them. Okay, so I talk about that a little bit on this slide. 5A discs can be repaired, 4A discs can be repaired. So this is a disc that slips out, then slips back in. It reduces on jaw opening, but we have to make sure that the shape of the disc is normal and it's amenable to a repair. We can do this in children and try to maximize the growth potential because we're reestablishing the growth center of the condyle. These other stages are discs that typically need to be removed and grafted. Like I said, the 5B can sometimes project to be stable without surgery. So the ones that we're operating on, they're painful, they're symptomatic, there are occlusal changes, and there is objective data on the MRI scan that the articular disc is not where it should be, it doesn't look normal, and the condyle is abnormal. So there's a reason that you operate, and it's not only pain. The next slide that looks at the symptoms and the presentation of people that have pain is really, I think, of the utmost importance. When people come in to all of our offices complaining of facial, head, and neck pain, it can be overwhelming trying to figure out what the source is and therefore how you can treat them. So again, Dr. Piper has organized this for us and we need to utilize it. These are the pain pies. So this is the way we look at every patient that walks in the door. They're worked up, they're in a lot of pain, they're telling you how many tests they've had done in the past and how many doctors screwed them up and all this stuff. You've got to put that out of your head and be organized, and start to look at the pain pies, start to check off where these things are occurring. Pain pie 1 looks a lot at the masticatory system and the joint. What do the bones look like? We talked about that. Is there palpable pain or palpable changes in the masticatory muscles that could be explaining their pain? Are they pointing to the temporalis? Do they tell you that it hurts after clenching and grinding all night? That's a muscle issue. Is it intra-articular? Via exam, palpation, range of motion, plus what we see on imaging, is it likely that it's coming directly from the joint? Pain pie 2, is this trigeminal neuralgia? Does it fit the criteria for tic douloureux? Does that make sense? Is it odontogenic? Do they have teeth that have periapical abscesses? Are there tender teeth? Are there lesions noted on the x-ray and they're having referred pain? Is it cervical? So we look at the neck in every patient. Is this coming from vertebral problems or neck injuries? And there are specific patterns to the way those pains present themselves. In pain pie 3, probably the most complicated, is this complex regional pain syndrome, number 1? Is it fibromyalgia? Are there migraines? And to tell you the truth, it would be nice if we could pick one piece of any of these pies, but typically in our patients, it's a combination of all of these, which becomes very important because we have to be able to tell them, what can I help you with? What are you going to need a chiropractor for? What might you need a pain specialist to help you with that I can't touch with TMJ surgery? So those are important things. With CRPS1, complex regional pain syndrome, this is a sympathetic nerve dysfunction. And it was originally described in 1864 by Mitchell, who was an American Civil War surgeon. And what he noted with distal extremity injuries, fractures basically, is that people would heal from their fracture but have extremely high levels of pain after they healed. He would also notice other things such as skin changes, temperature changes, and this is when the complex regional pain syndrome was first described. Overall, it has to do with dysfunction and dysregulation of the sympathetic nerves in that area. And we call it a syndrome because we don't know everything about it yet. We're doing our best. There are many criteria that I'll show you later that are objective to try to understand if this is the diagnosis that we're dealing with, but it's still a syndrome. This is a patient that Mark saw years ago. She has a CRPS1 diagnosis. And before I go through the checklist, I want to show you a few things that we notice on these patients that are objective, meaning we can see these on physical examination and document. Number 1, this woman has what we call a mask facies. She doesn't like to animate. It almost looks like she's wearing a mask on top of her face. And we see that oftentimes in CRPS patients because of motor dysregulation. So where my mouse is right now, we have motor problems, and that's weakness, tremor, dystonia. She has weakness to the muscles of facial animation. We also see ptosis of this right lid. That's also a problem with dystonia and weakness. We see trophic changes. This is probably the most interesting thing for me as I was learning about this stuff. You can see how shiny the skin is. It's very crepe-like and thin. The trophic changes are physical things that can occur because of dysregulation with the sympathetic nerves. So when these people walk in the room, we can tell almost when they come in, this person might be running down the category of CRPS diagnosis. Now, we're also very objective with this. We go through this checklist. Does the patient have continuing pain which is disproportionate to any inciting event, yes or no? And it goes through yes or no categories for all of these things: sensory, vasomotor, pseudomotor, and motor trophic. and you've got to put a yes or no. And you do that with symptoms, what they tell you, and signs, things that you notice on physical examination. Now you go through all these things and you add them up at the bottom. If you have yeses in each of these categories and a no, could there be a diagnosis that better explains these signs or symptoms? They're positive for CRIPS. Any other pattern, they're negative. So again, we're using objective criteria. One of the other things just from patterning that you notice over time is chronic pain with a nebulous occlusion. I love when Dr. Piper was telling me that. Initially, I had no idea what he was talking about. But you get these people that have had pain for a long time, and then you run over into this category, the motor trophic changes, and they have weakness, tremor, dystonia. They cannot get their bite to sit in the same place. They tremor, you can see the fasciculations in the muscles. Very interesting stuff. We can't ignore it. So with pain patterning, try to identify the patterns and layers of pain. Look at the structural causes, teeth, sinuses, cervical spine, and the joint. Check for CRPS1, fibromyalgia, and migraines, because they can make your life a lot more difficult if you're not looking for these and treating them. And use diagnostic nerve blocks. All of this data is obtained through the history, physical exam, and imaging. They all need to be done. And the reason why I bolded nerve blocks is we'll talk about those a little bit. The concept is that you want to try to nail down where the pain is coming from. So you block a nerve, see what it takes away, and you attribute that pain patterning to that particular nerve. So for example, let's say that we block the superficial cervical plexus. This patient has right-sided facial pain, and we block the entire plexus at Erb's point. And they tell us, oh my gosh, my jaw moves easier. I'd say 70% of the pain is gone. And we notice maybe some skin color changes. We can say that it's possible that there is cervical intervention from cervical spine problems, as well as sympathetic nerve problems, because the sympathetic nerves run with these. Then we can say that 30% of their pain that wasn't taken away could be attributed to the temporomandibular joint. Now let's say we go into another patient and we block the joint, the auriculotemporal nerve, and it takes away 100% of their pain. And we go back and we look at their images, we look at their bite, and it says, yep, that's a diseased joint. There is pathology that we observe in the joint with our imaging and secondarily with their occlusion and their skeleton, and we take away all of their pain when we inject that area. I think you're on the pathway to treating this person successfully because you have an accurate diagnosis. This is just for educational regions. The stellate nerve block is done by our anesthesia colleagues to block the stellate ganglion. It's a deeper block that's close to a lot of vital structures, so typically they're using an ultrasound, and they get profound improvement in CRPS patients because they're blocking the stellate ganglion proximal to where the nerve fibers in the head and neck branch. So lastly, in the triad, we're looking now at the occlusion, the skeleton, and the airway. These are often, but not always, secondary to deformities at the temporomandibular joint. On occasion, they can be the cause or contributing factor to damage of the temporomandibular joint. And what could be an example of that? A patient who has maxillary trauma, Lefort 1 fracture, poorly reconstructed or not reconstructed at all, creating a malocclusion that then can secondarily cause problems in the joint. That would be an example there. So let's look at occlusion first, secondary to problems at the foundation. Okay, so this one is what we typically see. The last example I gave is the abnormality. But what we typically see is that these other things change because the joint changes. This relates occlusal drifting to damage in the joint foundation. A change in the joint foundation will always cause a change in the occlusion. You have to learn to read the occlusion. And this is the example of the three-legged stool. You've got your joints and your bite. If one joint loses height through inflammation, degenerative changes, lack of growth, the occlusion or the table has to change. it's going to be an asymmetric table. This is an easy one, just for illustrative purposes. So here's one of our patients. She is status post-trauma many years ago, so you can see she had a condylar fracture on the right side, and it was never repaired, so she had resorption. In addition to this, she has lots of other problems, tons of degenerative arthritic changes. You can see that in the left joint, a large subchondral cyst, abnormality in the joint spacing, flattening of the condyles. But if we were to look at this and just think of our three-legged table, and we have lost all of this structure in the right condyle, all of this structure is gone, what should our occlusion look like? Well, here we go. I gave you an easy one. This one makes sense. The patient comes in an MIP, and they have an open bite on the opposite side. They've lost height in the right ramus condyle unit. When we push them into a fully seated condylar position, that's exhibited even more. And the reason why we do this blue bite that covers only some of the teeth is this is how we take the CT scan in the office. And as you know, the blue bite will be captured in the CT, so we don't want to obscure all of our anatomy there. And then we go through dynamic range of motion, which I'm, in this patient, only going to show incisal edge position. She's protruding forward to an edge-to-edge position, midline to midline. My blue arrow shows that she has lost disclusion on the right side. Okay, and the reason for that is because this ramus condyle unit is shorter. As the ramus condyle unit translates forward, it comes down the articular eminence and should disclude in conjunction with contact on the anterior dentition, but we don't see that disclusion here. Another cause of this could be flattening of the articular eminence itself. Here's a 30-year-old patient who presented with facial pain. You can see that there are some facial asymmetries here. And look at her occlusion. So we're reading the bite. This section, we're reading the bite. So here she is in MIP. If she walks into your office and you tell her to bite down, that's not bad. I mean, look at that molar. That's like a class 1. Her midlines are coincident. Now manipulate her into a fully seated condylar position. Massive open bite. We uncover the overjet. And then here she is in the incisal edge position. So she is protruding forward edge to edge with the incisors. She's lost so much height in the joints, and we're showing this with the animation, that she can't disclude the posterior teeth. So here you can see the condyles are forward. They're in the edge-to-edge position. She's lost height in that joint, both through the bones, and here's our disc. Okay, so oftentimes people will say to me, well, so what? If the disc is sitting between the bones, that's just a few millimeters, right? Well, it's the thickness of the disc. It's the superior joint space and the inferior joint space. And that is enough. That's 3 to 4 millimeters to correct an occlusion. Here's another patient, facial asymmetry, temporal headaches, still during growth. Again, the MIP looks pretty darn good. Then you put her into a fully seated position and you unravel what's going on the foundation. So again, point being made is if you go through these maneuvers, the fully seated position, incisal edge position, you can unravel things that are happening at the foundation. So the joint has to respect the occlusion, and the occlusion has to respect the joint. And we think about this preoperatively, intraoperatively, and postoperatively. It's required. So here's a 24-year-old female with pain, poor function, had a posterior open bite postoperatively after a disc repair. So a surgeon did a disc repair on her and said, it went great. I got the disc back to where it should be. It's creating more space in your bite, so you're going to have an open bite on that side at your molars, but don't worry, it'll get better. So sure enough, it quote, did get better. Here she is when she came to see Dr. Piper and I. This is her MIP position and her fully seated position. There is almost no change. So there's no wiggle room in this patient. So why did this posterior open bite get better in this patient when she had one when the disc was in the correct position, because the occlusion was not respected. So here she is when she saw us. Here's the left condyle, the right condyle. Remember that there is no change between her MIP and her fully seated position, of course, because we can't really seat her anymore. She has a tight occlusion that does not match what the anatomy of a healthy joint would look like. So where's the only place that this disc could be? Right here. Okay, there's no space for that disc to be sitting in the 1 o'clock position. I'm sure the other surgeon got it there, but as soon as she started biting down, she drove the condyle posteriorly and the disc slipped again. So here we are, we're looking at her MRIs. Here is her disc outlined on the sagittal view. So sure enough, even without looking at this particular MRI, we see that it has slipped anteriorly when she occludes. And here's the disc on the right side. Same thing, anteriorly displaced when she occludes. So again, why did her repair fail? The occlusion was not even thought of. It wasn't part of the pre-op assessment, and it wasn't part of the post-operative protocol. You have to respect the occlusion. Surgeons have a tendency to not do that when they're thinking about the temporomandibular joint. They go into the foundation, they operate, and they hand them back to the referral without looking at what happened in the joint. So now we're going to talk about the things that you can see as soon as they sort of walk into your office. So the diagram here shows an osteochondral growth deficiency. Eventually, we're going to see a mandibular growth deficiency, and we're also going to see maxillary growth deficiencies or altered maxillary growth. These things all happen in conjunction in the growing patient. So if one thing sets off the cascade, be sure that the other things will occur as well. So here is a 32-year-old who presents with pain, poor function, bite changes. She's had orthodontics. She's been in splint therapy. But not only does she have pain and functional problems, but as you can see from these photos, there are skeletal issues. So there are lots of obvious findings in this patient. If you're looking at her from both the sagittal and from the frontal in repose and smiling, this is our long face patient. She has really poor lip support. There's an interlabial gap. She has mentalis strain. So there are things going on with her skeletally. When we look at her foundation, what I want to point out here is the volume. Look at these condyles, 95 on the right, 72 on the left, and remember we said normal is 120 to 140. So this has been a chronic issue with her. That is an osteochondral growth deficiency. So her injury occurred as a child. And look at the secondary skeletal issues that we see here. A clockwise rotated mandible. Oral surgeons and orthodontists, by convention, look at the face like this in profile view. So this is clockwise rotation, meaning the mandible is rotating closer to the neck. We have a decreased cervical mental distance, increased lower face height. So subnasally to menton is increased versus subnasally to glabella. We have a steep mandibular plane angle. There's an interlabial gap. That should be in a young, healthy woman, that should be 2 to 3 millimeters. It's 10 millimeters in her. Excessive tooth show at rest because of vertical maxillary excess. Short ramus condyle units. And could that be the reason why the maxilla grew too far inferiorly, because it wasn't balanced by a normal mandible? Possibly. Antagonial notching, anterior open bite, relative class 2 dental and skeletal relationship, and thin alveolar bone at the facial of the lower ones, which we often see with these patients. Now, the reason why I put relative, and I actually think she's bimaxillary retrusive to a certain extent, but if you rotate the mandible up to a correct vertical dimension, if she didn't have vertical maxillary excess, you might be able to get her horizontal close to a class 1. at least with the sagittally deficient maxilla that we see here. Again, read the face. So we're looking at this woman. We see this long face. We see that her chin-neck distance is not what it should be. This angle is obtuse instead of being closer to 90 degrees. She has all of this dimpling, which is mentalis strain. She's using the mentalis muscle to try to close her lips. Excessive tooth show at rest and smiling. Very thin, poorly supported upper lip. So all of these things that we see with the face can lead back multiple years to a problem with the temporomandibular joint. Airway changes. Same thing. Osteochondral growth deficiency, maxillomandibular deficiency, altered airway. So here we have a 29-year-old, pain, poor function. Her bite has opened up after braces. She's been treated with multiple splints and muscle relaxants. I don't know how that's going to change her bite or fix her bite, but that's how people treated her symptoms. And here she is. This is quite obvious to everyone. Big anterior open bite, both in her fully seated and her MIP position. Look at her joints. 69 on the left, 105, 106 on the right. Lots of arthritic changes. So this patient has both an osteochondral growth deficiency and degenerative joint disease. So she has both of these things going on. I think her well-intentioned orthodontist at some point knew she had a small lower jaw, but kind of got the teeth to fit. But this is an active process. And if you don't fix the foundation, how can you imagine that the occlusion is going to stay where you left it? So the degenerative changes caused increased loss of condylar volume and clockwise rotation of the mandible, resulting in this anterior open bite. It's a moving target. The point of this patient was to show airway. Okay, so everything has fallen back in her. If you're looking at her face, look at this redundant submental tissue. If she had good chin projection, that would be nice and tight, the way it should be. But everything has fallen back. Not only the submental tissue, but also the muscles at the floor of the mouth and the hyoid bone, the base of the tongue and the soft palate, because the entire vault is small. So we have a 14 square millimeter minimal airway volume in this patient when it should be 90. So a huge loss in dimension in this particular patient's airway. So quickly, I'll go through a workup for the most part from start to finish as we do it here in the clinic, and then we'll look at a intraoperative video. So this is a 41-year-old female, bilateral pain and grinding, occlusal changes, inability to open. She has a 20-year history of facial pain, joint noises, and bite shifting. The pain originated on the left, and now it's on the right. She's had a recent closed lock, splint therapy, physical therapy, muscle relaxants, and nonsteroidal anti-inflammatories. Past medical history is significant for hypothyroidism, and she's had a left arthrocentesis. So that was the washout procedure that I talked about earlier. So here are her photographs. Quickly, she's obviously class 2. This is a convex facial profile. Okay, when you look at her from a distance, poor chin projection, everted lower lip, typically increased overjet in these patients. So we're already reading the face. We're getting to know her just as she walks in the door. Looking at her occlusion, she's pretty socked in. Okay, so she is in MIP here and fully seated condylar position here, and there's not much of a change. You can see that there's a width discrepancy here. The mandible appears a bit narrow for the maxilla, or there's been an asymmetric shift, which is likely the case because of the midline. We run through our CT scans with her on the two-dimensional films. We see 80 millimeters and 60 millimeters. Both of these condyles are very small in volume, so osteochondral growth deficiency, but she's also transitional because we see arthritic changes, flattening, bird's beaking, loss of joint space, so she's got degeneration on top of the growth deficiency. We look at her three-dimensionally to see the irregularities on both the right and left side. We can also see the decreased spacing. The Panorex gives us a ton of information. The one thing that is fairly normal in her is her overall ramus condyle height, which is over 60 on both sides, though it is shorter on the left by 3 millimeters than it is on the right. Her molar deltas show a class 2 bilaterally, more on the left than the right because of the mandibular asymmetry. The midline profile view gives us a lot of information, things that we can see on the physical exam, but we're actually getting objective data on with this view. The A and B, the measurement from A point, nasion, B point, should be 2 to 4 degrees. This is increased to 7 degrees, saying that there's an increase or more obtuse angle here, and who's at fault? It's the mandible. We can see that the mandible has fallen back. She's retrognathic. She would have a large overjet if these teeth hadn't compensated. Lower ones are flared, upper ones are upright. Three-dimensional frontal view. You can see where the arrows are that she's asymmetric at the gonions, the gonial angles, because of the asymmetry in her ramus condyle heights. And lateral shift. Okay, so why is she now having pain on this side where she hasn't in the past? Typically what happens with a small condyle is over time the condyle will want to seat medially in the fossa. Because everything is connected, this will push the other condyle laterally, and you'll begin to strain the joint in that area and pick up symptoms. And that's what we're seeing in her case. Her airway volume is small at 65. It should be 90. Sinuses are clear. Again, I said in the pain patterning, we want to look for other sources of pain. If she has a bad sinus, we need to know that. That can be contributing to her pain, not to mention the fact that it needs to be treated. And we're also going to look at the neck. So we look at the cervical spine from the sagittal, and we're looking for lordotic curvature as well as arthritic changes. From the posterior, we see that there is a shift of C1 where the arrow is. And from the axial, there's rotation of C1. So could the cervical spine be causing symptoms? Absolutely. Again, these are all the things that we're looking at. The MRI of the left joint, I didn't go too much into how we tile these MRIs, but this is very important. We look at the joint in the coronal view from the fully seated position all the way across from incisal edge to opening to assess what the disc is doing medial laterally. And we're going to do the same thing sagittally from fully seated MIP to open. So here, not only is our disc out of place, but we also see heterogeneity on the T1 film, stating that there could be avascular necrosis going on in this left joint. And there's our disc. In the right joint, we also see loss of T1 signal in the middle of the condyle, and our disc, is displaced anteriorly as well. The arrow down here shows on the sagittal view, we can see there's almost complete loss of normal marrow space in this patient. So pain patterning attributed to the TMJ and neck, we see pathology, so we see it. It's picked up on physical exam. She's told us about it in history, and we see it on these images. Poor function in trismus, structural joint damage, osteoarthrosis, avascular necrosis, Piper's stage 5A, active occlusal drifting, skeletal and airway changes. So all of these things are pointing objectively towards damage in the joints. So we're going to propose bilateral discectomies with autologous fat grafting to treat these problems. So when we do this, the patient is worked up on an articulator. This is the original bite. And then what we do is we build in, here as Dr. Piper states, duplicate the dimension of the original foundation. So we're adding vertical to the foundation that was lost. And as you can see, just by adding this to the articulator, we get nearly a class 1 occlusion with coincident midlines. Okay, now what that does is it distracts the condyle inferiorly and recreates what it should have been, the dimension of bone and soft tissue that was lost, and we replace that with the autologous fat graft. Okay, and there's our splint intraoperatively. So before we drape off the mouth, the splint is based on this articulator and placed with elastics. We use an endoral incision. So where I have my purple marker line here is where we draw out the endoral incision. You can see how small this is. It's about 2 centimeters. And what we do is the dissection is carried along the anterior surface of the auricular or ear cartilage. And the reason why that's done is the facial nerve runs right in this area. And if you start to go too anterior, you can hit the facial nerve, number 1. Or number 2, you can get into some of the vasculature in that area, which is the superficial temporal artery and branches of it. We're going to want to go down to a layer called the superficial layer of the temporalis fascia. And here's the ear to orient you a little bit. The blue drape is superior, and this retractor is anterior. So here is the temporalis fascia. It's going to be a glistening white layer of tissue. The zygomatic arch is going to be sitting here. The joint capsule will be down somewhere in this area. And here's our ear cartilage. We need to come through this fascia, deep to it, to get down to this cartilage, because that way we're protecting the nerve. We're reflecting the nerve anteriorly in that soft tissue so it doesn't get damaged. And again, that's cranial nerve 7. So here's a video, and we're going to zip through this. We have dissected down to the joint, and we've done the arthrotomy, meaning now you're looking inside the joint. Okay, where the suction is the superior joint space. We're going to irrigate that out. Now I'm going to click to the next phase here. In a second. Okay, so here we're grasping the lateral collateral ligament. This is holding the disc to the lateral of the condyle. Using the iris scissors, we're incising that ligament and we'll pop into the inferior joint space right there, and the condyle is at the inferior portion of the scissors. Okay, now we're in the joint and we are going to start removing the disc. So this is a cautery at the junction of the retrodiscal tissue and the posterior band of the articular disc. That is difficult to see sometimes. You have to do it by feel. The disc is a lot more dense than the retrodiscal tissue. So this is how we continue to do the dissection to remove the disc. Here, the cautery is at the medial of the condylar head, trying to incise the medial collateral ligament. Everything else has been freed up at this point. This is the most difficult portion of the operation because it's hard to see back there. And then the disc is delivered. What we are suturing here is the retrodiscal tissue. So this is going to be sutured over to decrease bleeding and keep a joint space, and also to create a pseudo-posterior band for the condyle to allow it to sit in a more centered position within the fossa. So there we are. The joint is clean. You can see the articular eminence here, the fossa, the condyle, the retrodiscal tissue, all very clean. And now we start to close the capsule. So this capsule will be closed with running sutures, except for one particular stitch, so we can insert a catheter to place the fat graft. And I'm going to show you that on the next slide. So here, as we continue to suture the disc, you can see that there is a small gap in this area where my cursor is. Here we are probing that gap. You can see how small it is, and we place the last suture in an interrupted fashion so we can tie it after we're done doing what we have to do with the catheter inside the joint. The catheter is in the joint now, irrigating any debris or blood. We remove the irrigation syringe and then attach the autologous fat graft that was harvested from the abdomen. This is then injected into the entire joint space. So like I said earlier, we're not suturing this down. This is cushioning all of the articulating surfaces of the joint as well as a portion of the lateral pterygoid muscle. And this ends up being a palliative medicament almost in the joint. A drain is placed and exits through the skin. This decreases edema. The disc is photographed. And the wound is closed in layers. The subcutaneous tissue is closed, and here we are closing the skin with a very thin 5-0 fast-resorbing gut suture. And the scarring ends up being minimal to nothing with these cases. So postoperative care is just as important in our office as preoperative and intraoperative therapy. The patient is maintained in this new condylar position for approximately 9 to 12 months after surgery by wearing the splint intermittently. So they're not wearing this the entire time. The first 3 months it's in the mouth most of the time, but then it's only worn in the evening. But the reason why the splint is used for this long is, again, going back to respecting the occlusion and the foundation, we're creating space at the foundation to place the fat graft. And that needs to be maintained. Otherwise, the grafts can be compressed or perforated and will not revascularize. Intraoperatively in the hospital and immediately post-op, we do aggressive ambulation and fluid replacement. So we have the patient walking quite a bit with their caregiver on the floor of the hospital before they're discharged. And as soon as they are discharged, we have them walking multiple times a day. We are going to see the patient for 5 days at the Piper Clinic after discharge, so we're keeping a close eye on them. With patients that require further pain control, sometimes ketamine is implemented, in-office nerve blocks, or even the stellate ganglion nerve block. Now, typically our protocol is to do that in the preoperative holding area with anesthesia, and the effects are advantageous for multiple days after that is done. We do have a chiropractor here in the office that does adjustments postoperatively, and then the patient is typically discharged to their chiropractor at home to maintain the cervical spine. Medications are very important to our postoperative protocol, and everything is prescribed for a reason. We use an anti-inflammatory. Usually this is going to be Relafin. Klonopin is used as the muscle relaxant. Trazodone or Elavil can be employed in the evening to decrease nocturnal bruxism. Antibiotics are used immediately post-op, and narcotics also for only the first 3 days. And we always get patients off of narcotics after this procedure. If they do require further narcotic care, that's done by a pain specialist at home. We employ a very aggressive anti-nausea protocol: Afrin, Tylenol, Prilosec, Miralax, and vitamins. And I do want to touch base on the vitamin protocol briefly, as we have seen great results from this. We are using vitamin D3, calcium, and 2 subfractions of vitamin K, MK4 and MK7. And the theory behind this protocol is that the calcification is maintained in the bones themselves. So the calcium is being pushed into the bone and not into the renal tubules and into the vasculature. And that is the 2 subfractions of vitamin K at work. So lastly, to summarize, the history of TMJ surgery is filled with successes and failures, but let's not forget the successes. In recent times, it's always been the failures. And like I showed, the catastrophes of the 1980s with the Teflon Proplast implant has really influenced the way people think about TMJ surgery, and that's not fair. On our end, it all starts with an accurate diagnosis. Is the pain caused by the joint? If it's not, and the patient needs, or their primary complaint is to take care of pain, then how could joint surgery be indicated? And we know that. MRI, CT imaging is required. Injury in the TMJ foundation directly distorts the occlusion, the face, and the airway. These are clues and patterns that we can all pick up on as practitioners. Some injured joints are stable and some are unstable. Even though they're injured, we may not need to do surgery. There is no radical treatment or conservative treatment. It's only the correct treatment. We operate only when necessary. Not all patients are created equal, and neither are the operations. So these are things that you have to take into consideration as the treating doctor, and that's where the art comes into play a little bit here. The occlusion must be assessed preoperatively and controlled postoperatively, and we need to recognize and manage CRPS1 before and after surgery if we want successful results. Again, I want to thank Dr. Nick Yanios and the CNO. I think this is a wonderful group. And, the whole concept of using objective data to guide treatment is something I believe in dearly. So thank you again, Nick, for having me.